Let us learn about rib dysfunction for the board exam. This is by far the most important part of this lecture, and I want you to understand this very, very cold. It's actually very easy. Sometimes students find this confusing, but I always tell students if you're going to learn two things for the board exam that are very similar, just remember one of them, and the other one will be the opposite. So you create some brain space for yourself. So, hey, let's go ahead and learn about rib dysfunctions. All right, by far, rib dysfunctions is basically a somatic dysfunction of the ribs that affects the movement or the position of one rib which is already altered or disrupted. So let's start with definition. Well, a somatic dysfunction of a rib in which movement or position of one rib is altered or disrupted. So that's a definition of a rib dysfunction. There are two most common types of rib dysfunction. Guess what it is? Take a deep breath in and breathe out. Oh, wait a minute. This can only be two, right? Because we only breathe in and breathe out. Thank you. All right. So we have inhalation dysfunction and exhalation dysfunction. Oh, let's take a look at the animation. Breathe in and breathe out. I want you to do the exact same thing. All right? Don't try to be a big boy girl now. This is easy. This is how you remember stuff at the boards. Repetition. All right. Here we go. So the first one is inhalation dysfunction, right? Which means if I take a deep breath in, look, let's stop right there. All my ribs just went up. Exactly. Went all the way up, and I expect every single person, every single rib should bring themselves down. So if I have a dysfunction in one of the ribs, what do you think is going to happen if I take a deep breath in? Well, the one that's going to be dysfunction is not one are going to come down. That's the problem. Exactly. That's what we call inhalation dysfunction or an exhalation restriction, which means in inhalation dysfunction, the dysfunctional rib will move cephalad during inspiration. However, when it comes time for it to come down, it's going to be, nope, I'm just going to stuck up right up here, all right? That's why it appears that rib is stuck up. So let's look at the diagnostic findings of inhalation dysfunction. Well, I highlighted here in this animation the pump handle ribs. Let's see how they work when they're going into exhalation and inhalation. Excellent. Stop right there. Well, remember the pump handle ribs. Which ribs are those? Let's recall. Well, those are the upper ribs, 1, 2, 3, 4, 5. And their primary motion is pump handle motion, right? Because they move like a hand of a pump. So what you're going to notice when you're going to diagnose these patients that have a pump handle rib inhalation dysfunction is the ribs will be elevated anteriorly. Shocker. Well, they're going to be elevated anyway because they're going to be up, right? They're taking a deep breath in. It's a pump handle. If I break the hand of the pump and I pull it all the way up and I stop right there, right? That's where the pump is going to stop. So the rib cage is going to feel anterior when you palpate. It's very simple. So what happens is the anterior part of the rib is going to move cephalad on inspiration, but it's going to be restricted on exhalation or expiration, right? So when you try to breathe all the way down, they get stuck. So if it's one rib, it's going to be stuck up there, okay? It's not going to move. Now, what's going to happen to the intercostal space above the dysfunctional rib? Well, it's going to be anterior narrowing. It's going to be narrowed because remember, if that rib is stuck, right, up there, and it's not able to move down, that decreases the space between the intercostal space, right? It's going to be lower. It's going to be smaller because that rib is taking extra space by staying up there when everybody else is down. That's how I want you to remember that. Also, the superior edge of the posterior rib angle is going to be prominent. Well, that makes sense, right? Let's see. If I'm looking at this rib here, the superior portion of it should be more prominent, especially on the posterior rib. So let's go to the back, all right? Well, this animation is not showing you exactly the inhalation dysfunction. I'm just using this as an explanation so you can kind of visualize things. But let's imagine this is the rib that's giving us a problem, right? Let's go back. So here we go. We go posteriorly, and we say, hey, this rib posterior is going to be more elevated, right? It's going to be more superior edge. It's going to be more prominent because anteriorly it's stuck up. Very simple. Now, what is the easy way for me to remember inhalation dysfunction? Well, check this out. Take that I in front of inhalation and try to turn it into a U. Oh, which means it's going to be up. Or, easier way, see the N in between the I, N in inhalation? Just flip that N up and it's going to be up, which means it's going to be stuck up, guys. This is simple. That's how you remember inhalation dysfunction. The rib is stuck up. Now, let's take a look at what happens to the bucket handle ribs. Well, let's revise bucket handle ribs again. Well, which ones are the bucket handle ribs? The bucket handle ribs are ribs 6 to 10, right? Ribs 6 to 10. And we've got ribs 6, 7, 8, 9, 10. Oh, right, exactly. Now, these ribs 6 to 10 are known as the bucket handle motion. When they're moving in with respiration, they're going to move in a bucket handle. It's like lifting the hand of the bucket up. Now, the only way we're going to appreciate this is to move this animation laterally, so we can appreciate the bucket handle motion of rib 6 to 10. So, inhalation and stop. So, laterally, that's how you're going to be able to diagnostic findings of inhalation dysfunction of a bucket handle rib. So what you're gonna notice is the lateral part, which is the shaft of the rib, is gonna move slightly upward in inspiration, but it's gonna be restricted in respiration. It's the same thing. The first one is anterior, laterally on the bucket, because the bucket hand is always lateral, right? Exactly. So you feel that and you say, oh, one of these ribs is stuck up. It's really stubborn, doesn't want to come down. Exactly. What's going to happen to the intercostal space above that dysfunctional rib? It's going to be narrowed, right? It's not being shown in this animation, but what's going to happen to that intercostal space, let's imagine between 6 and 7, if this rib 7 is stuck up, well, it's going to be kind of staying on top, so it's obviously going to decrease the intercostal space. What about the lower edge of the rib shaft? It's going to be prominent. It's going to be prominent. Now, what are you going to notice when you're actually diagnosing patients with a bucket handle rib inhalation dysfunction? Well, you're going to notice tenderness and tissue texture changes, right? The intercostal muscles are the mid-axillary line and the posterior rib angle. They're going to be tender. You're going to notice some tissue texture changes. If it's an acute, right, it might be edematous a little bit. It might be very tender, right? Also, you might notice some edema if it's an acute dysfunction. Remember, we learned that in chapter 1. So, compare that to the rib dysfunction in a pump handle rib dysfunction. Well, you're going to notice tenderness and tissue texture changes along the costochondral junction, right? The costochondral junction. So let's take a look at that. The costochondral junction is right here. So if you pop it along that area, if a patient has a rib dysfunction, which is inhaled, which is inhalation dysfunction, it's stuck up, they're gonna be like, ouch, that kind of hurts. Exactly. You're also gonna notice that the chondrosternal junction, costosternal junction, costochondral junction. Okay? And also the posterior rib angles. Very important that you remember that for the board exam. Now let's visit exhalation dysfunction. Well, let's take a look at the animation again. Now we exhale. See, that was easy. Let's inhale again. Take a deep breath. And breathe out. Perfect. See, we just did that together. An exhalation dysfunction is also known as an inhalation restriction. Well, let's think about this. If the rib was stuck up in inhalation dysfunction, what do you expect the rib to do? Or when it's dysfunctional? When we exhale. Well, it's going to be stuck down. Thank you. I appreciate it. How are we going to remember that it's down in exhalation dysfunction? Well, actually kind of gives it away. The first letter of exhalation dysfunction starts with E. So let's count A, B, C, D. There you go. D comes before E. Thank you. Add a D right there, an invisible D, and think of it. It is down in exhalation dysfunction. So it kind of even sounds, it kind of rhymes, right? Down in exhalation dysfunction. So because D comes before E. So what happens? Well, the dysfunctional rib will move caudate during exhalation, right? It's going to move down, which is okay. However, that dysfunctional rib will not move cephalad during inhalation. So this animation is not going to show you, but we're just going to imagine. Let's take a look at this animation. See how during inhalation, all the ribs kind of come up. But here's what happened in exhalation dysfunction, right? The dysfunctional rib will move caudate, right? It's going to move caudate during exhalation. So let's exhale. Perfect. The rib moves down. However, let's imagine that this rib 1 is the one giving us a problem. It's the dysfunctional rib. Well, what will happen is that rib will be stuck down, which means, imagine if this rib was stuck down, if we try to inhale, it's not going to move up, okay? It's going to stuck down, all right? That is what an exhalation dysfunction is. Now, let's look at the diagnostic findings that we're going to notice in an exhalation dysfunction for pump handle ribs versus a bucket handle rib. Well, let's highlight the ribs we care about. So, we said we want to talk about ribs 1, 2, 3, 4, and 5. Well, those are the pump handle ribs. What's going to happen to an exhalation dysfunction if the pump handle has a dysfunction? Well, the ribs are going to be depressed anteriorly, right? They're going to be depressed anteriorly. And the anterior part of the ribs are going to move caudate on expiration, and they're going to be restricted in inspiration. So imagine, let's say rib 1 to 5 actually has an exhalation dysfunction. It means that rib is going to be stuck down. It's going to be stuck down. So especially, you tell this patient to take a deep breath, right? During expiration, the rib is going to come down, but when it's time for the ribs during inhalation, the rib will be stuck down. Also, if all those ribs are stuck down, what will happen to those intercostal space? Well, there will be an anterior narrowing of the intercostal space. It just makes sense below the dysfunctional rib. So let's even say just 2 ribs are dysfunctional, right? Rib 2 and 3, right? You're going to have narrowing that's going to happen below the dysfunctional rib because these ribs are stuck down. Also, the inferior edge of the posterior rib angle will be prominent. Now, remember the touch mnemonic for somatic dysfunction. That's how we diagnose somatic dysfunction in osteopathic medicine. Well, we said we're going to notice tenderness and tissue texture changes along the costochondral junction, the chondrosternal junction, which is basically between the cartilage and the sternum, and the posterior rib angles. What about the bucket handle ribs? Well, these ribs are going to be depressed laterally. So let's take a look at those. We said the bucket handle ribs are ribs 6, 7, 8, 9, and 10. So let's take a look at them on the lateral portion. So to diagnose, to find the findings of an exhalation dysfunction, well, this ribs, the lateral part, which is the shaft. This is the shaft of the rib. You can see with the mouse, that's the shaft of the rib. It's going to move slightly downwards on expiration and restricted on inspiration. So if I try to take a deep breath, these ribs are not going to move. So if one of these ribs is having issues or we have a dysfunction, it's basically going to be stuck down, all right? It's not going to move during inspiration. Also, you will notice a lateral narrowing of the intercostal space below the dysfunctional rib. So if it was rib 7 that was dysfunctional, you should expect that if it's stuck down, it's going to take space. It's really going to take space, and it's going to cause narrowing of that intercostal space between ribs 7 and rib 8. If we have to look at the third mnemonic again, we're going to notice the patient is going to have tenderness and tissue texture changes right along the intercostal muscles at the mid-axillary line, okay, at the mid-axillary line. So this is the axilla. So mid-axillary line is the line kind of going down that way, and the patient will have also tenderness along the posterior rib angles. Now, trigger point, you must know the difference between inhalation and exhalation rib dysfunction. Let's revise that again. Remember, inhalation, remember we can change the I to a U or flip the N in front of in and it becomes U. It just means the rib is stuck up. Exactly. And for exhalation, the rib is stuck down. Remember that. That is very, very important. Now let's take a look at group dysfunctions. So, what's the definition of a group dysfunction? Well, an inhalation or exhalation rib dysfunction, which the movement or position of two or more ribs is altered or disrupted. So remember, we've talked about single rib dysfunctions previously. Now we can have a series of ribs that has a group dysfunction. Now, in these cases, there's usually one rib that's actually responsive for causing this dysfunction, right? So it sounds like multiple of them are actually dysfunctional, but actually there's one key rib, okay? That rib is known as, I call it the bad boy rib, okay? It's the bad rib that's causing everybody problems. If you ever have a rib dysfunction, guys, it hurts. You know what it feels like? Try to take a deep breath with your ribs stuck. Maybe, and you're going to feel so much pain with inspiration. You're going to have pleuritic chest pain because the nerve, intercostal nerves right along the rib lines. So patients that have this kind of dysfunction, they have chest or rib cage pain, and it's excruciatingly painful. So with group dysfunctions, so let's select rib 2, 3, and 4, right? Let's assume those are going to be our dysfunctional groups of rib. Well, in inhalation dysfunction, the key rib is the lowest rib of the dysfunction, right? So if ribs 2, 3, and 4 are dysfunctional, which of these ribs will be the key rib? Well, the correct answer is going to be rib 4. Exactly, because it's the lowest rib of the dysfunction. That's how you're going to treat the patient. How about in exhalation dysfunction? Let's say these ribs are stuck down. Remember, in exhalation dysfunction, the key rib is the uppermost rib of the dysfunction. So the correct answer is going to be rib 2. Very important high yield information for the board exam. Know the key rib in group and somatic dysfunction. So how do we treat patients that have group dysfunctions? Well, the key thing is find the bad rib. That's what I call it, right? It's always a bad apple that is causing patients to have severe amount of pleuritic chest pain. So the key is to identify the key rib, because when treating the rib somatic dysfunction, treatment is directed at the key rib. So for example, if a patient has a group dysfunction at ribs 2, 3, and 4, right, osteopathic treatment should be directed to rib 2, because if they have a group exhalation dysfunction, you should treat rib 2. If you have a group inhalation, you should treat the lowest rib, which would be rib 4. That brings us to the end of our lecture on ribs dysfunction.